teaches psych mental health. Dr. Kathy Carlberg is the block lead for our semester. She also teaches pediatrics. Dr. Doris Lovato also teaches maternal health and OB. Lecture time and place will be Wednesday and Thursday from 4 to 6 p.m. All classes are virtual. I do use Bongo for lecture. If you need to have office hours with me or a meeting with me, then I do use Google Hangout. Lectures are pre-recorded. Please listen to the PowerPoints before you come to class because you will need that information during class to be able to ask questions. We do not do any type of lecture during class. We do class activities such as quizzes through WK or Wolters Kluwer. I may use Kahoot to do some quizzing. We'll look at some case studies, do a CIWA score, and get orders for restraint and seclusion and medication for emergency situations. So for rotation 1, your test is going to be 9:23 at 1600. The class will end on 9:23, and the clinicals will end on 9:22. Rotation number 2 will end on 10:27 with a test on 10:28, and your last clinical will end on 10:27. Rotation 3 will end 12:09. That's when you will also have your exam. Clinicals will end on 12:06. So exams are given during the assigned class time, which means your exam will be at 1600. There's one exam, 50 questions, which also includes 3 math questions. You will have 80 minutes to complete it. If you have ADR accommodations, please send me a text the morning of to remind me, because sometimes I inadvertently may leave somebody off the list, and I want to make sure I don't do that, so please remind me. So you can only look at your exam 15 minutes after you've completed it through ExamSoft. You may only look at the questions that you got wrong. The exam scores will be uploaded no later than 7 days after the exam. There is a pre-lecture quiz of 10 questions, which is 5 points, and it's due at the start of class time. Testing etiquette, all students will begin the exam at the assigned times. All right, so since we're in this class at 1600, your exams are at 1600, not at 1300 or 1400. So in WK or Wolters Kluwer, there's a Prep U. There is an assignment that's going to be due every lecture day, and it's worth 10 points. It's due by 23:30, within 72 hours after the lecture. To obtain the points, you must achieve the points for the mastery level. And in this class, in this semester, it's mastery level number 5. And it has to be submitted on time. Please make sure you get it in on time. If not, there is a 10-point deduction for each day that you're late. So advising. Your current rotation faculty is your advisor for the whole semester. So if you have pediatrics first, then Dr. Carlberg is going to be your advisor. If you have OB first, then Dr. Lovato will be your advisor. And in psych, it's going to be me. If you know that you are missing classes or there are classes you still need to take, make sure you let us know that, because even though we do a file review, things do get missed. And you do not want to find out that you cannot graduate because you didn't take a certain class. So please look at your transcripts, be familiar with them, know what classes that you may be deficient in. All right, so the instructors. Carol Ariza will be teaching the Tuesday clinical in the second and third rotation. She teaches at Sonora normally. Tiana Preston also teaches at Sonora, and she will be teaching on Saturday and Monday, and she'll be teaching all 3 rotations. Chris Walter teaches at Banner South Campus, and he teaches on Fridays. And Will Williams teaches on Fridays over at Sonora. Christopher Walter, I forgot to put in that he is a master's in education as well. Dr. Karlberg is our block lead. Yolanda McCoy-Stokes is our assistant dean, and Dr. Joseph Gaw is also our dean. Clinical activities on day one, you'll turn in a Tell Me About You. You'll do a daily SBAR, which can be found in WK or Walters Kluwer. There'll be a Walters Kluwer vSim assignment, a DocuCare assignment. Please, it will behoove you to complete that assignment as thoroughly as possible, because if it's not done in a thorough manner, it will be returned to you, and then you have to get it completed by that day. All right? There's a mental health flyer which will be due in week number 4, and we'll give you more information about all of this during your clinical time. Clinical time, 7 a.m. to 1900. It is mandatory that you attend. You must be there on day 1, and you must be there on the last day. You can have one absence in this semester. Please don't decide to take the day off to attend your significant other's baseball game, because don't forget, we're getting into winter, and that's when the cold and flu season hits, and inadvertently somebody may end up getting ill and have already taken their absence, and then they're going to be out of the program until there's a seat open later on. You are considered tardy if you show up at 7:05, and you are considered absent if you show up at 7:15. All right? There are required virtual face-to-face meetings at the beginning of clinical, midday, and your instructor will tell you what time that will be, and then at post-conference. All right, and that's it for that. Any questions? All right, let me stop sharing that screen. Well, that thing always scares the heck out of me. And get into the other PowerPoints. Okay, so let's talk about, uh-oh, I lost my screen. Oh, that scares me. Alrighty, here we go. So, foundations of psychiatric and mental health nursing. Very difficult to define. There is no single universal definition about it. It can be ever changing. It's in a constant flux. There are influencing factors about with personal perception, relationship perceptions, and then also environmental. So there are different disorders that affect our mood, behavior, and thinking, and we will take a look at those disorders as we move along in this rotation. A lot of the disorders can cause significant stress or distress or impaired functioning. So, factors that contribute to mental illness can be the biological makeup of the individual. They may have a perception or a delusional system that keeps them out of touch with reality. They may not be able to communicate effectively, and they may have inadequate social support. They may also social culturally have a negative worldview, and also there may be a lot of negative stigma attached to mental illness, and there often is. One of my favorite sayings, as a matter of fact, is not to label people, but to label jars. So there's a manual called the DSM-5, or Diagnostic and Statistical Manual of Mental Disorders. It's published by the American Psychological Association, and it has nomenclature that are standardized, and it presents the characteristics that the individual must experience in order to be qualified for certain diagnoses. So it helps the practitioner to be able to identify what's going on with the patient, whether it be psychiatric, medical, or psychosocial and environmental problems. In ancient times, people viewed illness as displeasure of the gods. It may have been punishment for their sins, or it may have been because they felt that they were demonically possessed. I did a research study, and in 2007, there was actually a paper that was published that questioned whether or not psychiatric patients, specifically schizophrenic patients, were possessed by demons. Aristotle said that there were imbalances in the blood, the water, the yellow and black bile. Christians viewed possession by demons and distinguished, the demons weren't distinguished until the Renaissance era. But they did a lot of believing about demonic possession. So in the 1790s came the period of enlightenment. They put people into asylums. They started to tighten up the moral treatment of patients. Freud, who I call Captain Obvious, wrote his scientific studies about the treatment of mental illness. Then in the 1950s, we started to develop psychotropic drugs. We started to look at deinstitutionalization of patients, and we tried to get them some disability for their disorders, and also to change commitment laws. Prior to that, commitment laws were pretty harsh. It was not uncommon in the 30s and 40s and even into the early 50s that if you had a young child who was incorrigible, you could have them committed to a state mental institution where oftentimes they did a frontal lobotomy on the child to make him much more controllable. So currently we know that 44.7 million people in the U.S. are mentally ill, though only 19.2 million receive treatment. 15 million adults and 4 million children are impaired in their ability to function in their daily activities, and the economic burden exceeds that of the cost of cancer. It's one of the leading causes of disability in the US and Canada. Children and adolescents are being treated for mental illness earlier because we do know that the earlier that you're able to identify and intervene, the better the outcome is. But even though we're stepping up in our recognition and treatment options for the mentally ill, individuals who are homeless or individuals with substance abuse problems oftentimes are lagging behind in care. So one of the big things that we look at is the revolving door. That is the patient who comes and goes all the time. And oftentimes what they do is the ER hop, or they will hop through different units here in Tucson. Gone are the days when we used to be able to have a patient in the hospital for 30 days. Now the average stay for a patient is 72 hours. All right. We can no longer get in and really get deep into the problems that the patient is facing. We pretty much do a very brief treatment. Sometimes it's not all that effective. There's a very high recidivism rate in alcohol and drug abuse treatment. There's a thing called dual diagnosis, and you will need to remember this. That means that in our field, in psych, we treat chemically dependent patients who have a psychiatric disorder, such as bipolar disorder, depression, schizophrenia. All right. Homelessness, about 33% of the patients are homeless and also associated with substance abuse, and 33% of individuals who are chronically homeless have some sort of mental health issue, and there truly is a lack of community resources. Here in Tucson, a lot of their community resources are covered by the state and also by the county and also by the sin taxes, or the taxes that are paid on not drugs, but alcohol and tobacco as well. But as you can imagine, whenever budgetary cuts hit, the first place that gets hit are not only schools, but also mental illness treatment centers. So the Healthy People 2020 objectives were to increase the number of people that we could identify and intervene with and get help, were to decrease the rate of suicide and homelessness, um, increase employment for individuals who are seriously mentally ill, and provide more services for individuals who may be incarcerated. However, with the onset of COVID just a few months ago, a lot of this has been on hold or has taken a turn in another direction. So community-based care, there used to be a lot of day programs, but because of funding, there's very few that are available now. They are preferable for treatment because they do take care of the individual during the daytime, and the individual can return home and back into their social circle where they will, we feel, recover faster and will stay more compliant with her treatment regimen. All right. But managed care, with the pre-existing conditions, ruled out a lot of that. But thank goodness for Obamacare that eliminated that pre-existing clause. Oftentimes, mental health is a separate covered entity with health insurances, and oftentimes it's really restricted. So, unfortunately, if you don't have private insurance, then oftentimes you're going to have to rely on counties of residence for payment. There's also Medicare and Medicaid and the mental health parity insurance coverage. Okay. Culturally, cultures influence how people feel about mental illness and what they do about it. All right. Linda Richards was the first psychiatric nurse. McLean Hospital in Belmont, Massachusetts was the first training site for nurses, and we looked at developing a lot of somatic therapies. In other words, treating a lot of the physical along with the emotional and mental. So we just began to take a more holistic approach and view of taking care of the mentally ill patient. So the first psychiatric textbook was published in 1920. Okay, Johns Hopkins was the first school of nursing to include psych nursing, and the National League of Nursing in 1950 required schools to have a psychiatric nursing component. Hildegard Peplau, she's a nursing theorist. She's also known as the mother of psychiatric nursing. Mello looked at the client's psychosocial strengths and also their needs, very similar to Maslow. The American Nurses Association wrote the standards of care that included care for the mentally ill patient, and the psychiatric mental health nursing phenomena of concern you can see in your book in box number 1.2. So what can we do to help people? We can do counseling. We can do what's called milieu. Wherever you're sitting right now for this lecture, that is your milieu. Whether it is your milieu of comfort, such as my bedroom, or a milieu for education, which may be an office where you're studying, that is known as your environment or your milieu. Self-care activities, we should be able to take care of ourselves. We do a lot of teaching with all of our clients. Case management, we provide care for ancillary services such as whether or not they may need a home health aide to help them to bathe, whether or not they may need shopping services, or they may need things like Meals on Wheels and health promotion and maintenance. We also can provide them with psychotherapy at the advanced level function, prescriptions, okay, consultations, evaluations, clinical supervision, and also program development. So, oftentimes nursing students are afraid that they're going to say the wrong thing. This is the one rotation where I do want to warn you, it's not okay to say things like, "Are you nuts? Why are you acting so crazy?" Okay, so be real careful with your verbiage when you're talking with psych patients, because they tend to be very sensitive to that type of vernacular. A lot of students don't know exactly what to do. Um, and that may be because of the preconceived notion that psych patients tend to be more violent, unpredictable. They often fear rejection, but I can tell you as a nurse, rejection, you have got to quit being so sensitive to it because it's all about rejection in a lot of cases. Be careful about asking personal questions of the patient. If the patient asks you personal questions, you are not to give them any personal information about you. All right? Sometimes there is bizarre behavior. Believe me, I've seen it all, but there are still things that shock me. And the best thing to do is not to react, because oftentimes that may be what the patient is trying to do, is to get a reaction from you. Physical safety, big concern. Environmental safety, you should also have situational safety, which means you should know where people are in relation to you at all times. Okay? Encountering someone you know. If that were to happen, if we were in the clinical situation, then I would move you to another unit. And dealing with similar problems or backgrounds, sometimes that little bit of experience can actually help somebody. All right, so you've got to be self-aware. You've got to know what your feelings and beliefs are. We all have unique perceptions and unique beliefs, and that's what makes us so individual and so interesting. All right. Sometimes there can be conflict, but remember that in nursing, we don't have an opinion. Our opinions don't belong in what we do. If sometimes patients will ask me, "Well, what's your opinion about that?" I don't know. What's yours? Okay? We need to be able to accept differences no matter how bizarre, how strange, or how out of line with our personal beliefs that may be. All right? And then self-awareness through reflection. What is it that we can do to make ourselves a better nurse, a better person? All right? All right, hold on and let me change PowerPoints real quick. All right, how about, well, let's go ahead and go on. Okay, so treatment settings. Inpatient hospitals, most common setting nowadays. Rapid assessment, stabilization, average stay is about 72 hours. We do case management, discharge planning, partial hospitalization programs, the patient comes for the day. Residential settings, oftentimes the patient goes to group homes, supervised apartments, board and care, adult foster care, or respite, or crisis housing. Residential settings, they're transitional. The patient usually can go there for a short period of time, and then they have to find alternate living arrangements. They can also be in programs where they may be able to live there for about a year, but there's also conditions such as they have to have a full-time job and they have to be able to contribute to the household. And then they can be put in group homes or residential facilities. So services, all about recovery. All right, we want to keep the patient symptom and symptom free and have them stick to the medication regimen, and we want them to be able to learn new coping skills as well. We want to reintegrate them into the community. We want to empower them to help them to seek education, to seek a job, to seek healthy interpersonal relationships, and to seek healthy behaviors as well, improve their quality of life, and hopefully they'll be able to move to a higher level of recovery and be able to reach out and help others. So the clubhouse model says that there are 4 guaranteed rights they should have a place to come to. They should have meaningful work and relationships and a place to return. So it's a lifetime membership. And the physician and the client relationship is the key to this. And we focus on health, not on the individual's illness. The Assertive Community Treatment Act, most effective approach, getting them back and reintegrated into society. We want them to be participants in their care, and we want them to be able to designate when they want that care and when they're ready for it. And we want them to be able to achieve milestones. All right. So, homeless individuals mentally ill, they tend to spend more time in jail. All right, spend more time in shelters as well. They have a great deal of barriers when it comes to trying to get employment because a lot of times they cannot focus on the employment. They may not have transportation. They may not have appropriate clothing. The biggest problems that we have with mentally ill patients, especially bipolar patients, schizophrenic patients, is that they tend to go off their medications. And when they do that, they decompensate psychiatrically. And it's hard to hold down a job when you're completely psychotic. Okay? There are programs, the PATH program, an access demonstration program, which helps to keep them in a regimen and hopefully help them towards recovery. Individuals who are incarcerated, we want to get them out of the institution. We want them to be able to reintegrate into society and to be able to be functional. And we want them to be able to achieve personal goals such as education and employment. Barriers to successful reintegration, poverty, homelessness, substance abuse is a big one, violence as well, and victimization, and oftentimes self-harm. But now with the COVID thing going on, that is also, I believe, a barrier to being able to get people successfully reintegrated. Military veterans and active duty, increased rates of suicide, homicide, injury, physical illness. Sleep disorders is a big, big issue. Also substance abuse and also marital and family dysfunction. Oftentimes they're reluctant to seek treatment. Oftentimes the Veterans Administration system is not a very helpful system for them to be able to rely on. And oftentimes too, there's a lot of stigma and the treatment may not be available. Okay, interdisciplinary team. The pharmacist, psychiatrist, psychologist, psych nurse, social workers, OT, RT, and voc rehab. So we want to teach people about interpersonal skills. We want hopefully to help them with being able to accept, to be able to empathize, increase their knowledge base, and that's going to be through education. Increase their communication skills, and that's also going to be with education. We want them to be able to be assertive and be able to problem solve and teamwork. We do look at risk management for things like suicidal ideations, homicidal ideations, recidivism for drug and alcohol. Home care, we want to be able to decrease their stress, want to identify early mental health issues. We want to be able to monitor and coordinate their rehab programs and also look for issues such as substance abuse, domestic violence, depression, child abuse. All right. So self-awareness issues, the biggest thing, empowering clients to make their own decisions. All right. And that's it for that lecture. Thank you very much. I will see you in class. Bye.